staging for taking biopsies for mediastinal tumors. The therapeutic indications are pleurectomies, your wedge resection, segmentectomies, lobectomies, decortications, mediastinal tumor excisions, thymectomies, esophagectomies, and laparoscopic your VATS sympathectomies, and surgeries for chylothorax. These are the therapeutic indications. Now, it has been clearly shown that the benefit of one of the major benefits of VATS are, firstly, it decreases postoperative pain. As being a minimal invasive surgery, decreases narcotic requirement, which results in decreased respiratory depression and decreased incidence of pulmonary atelectasis. A large number of studies have shown that in patients who are high risk for anesthesia, the incidence of complications with VATS is less as compared to patients undergoing open surgeries. And VATS has also shown improved outcomes in elderly patients also. Now, the surgical technique of VATS involves giving incisions over the chest wall, and through these incisions, ports are inserted. For one port is for introducing your camera, and the other two ports are used for introducing your instruments. These could be surgical instruments for dissecting or for introducing your stapling devices. So these we can see that this is the ports for the VATS surgery which have been inserted. One of the main thing in VATS surgery is the surgical window for the surgeon. The surgeon requires a very clear lung collapse should be, a very proper lung collapse should be there. If the lung collapse is not proper, the surgical field will be, for the surgeon will be hampered and do a successful surgery. So a proper lung collapse is very essential for VATS surgery. For that, quite often, a lot of surgeons like to do carbon dioxide insufflation. But insufflation of carbon dioxide into the thoracic cavity leads to certain hemodynamic alterations. It has been seen that insufflation of carbon dioxide leads to a rise in pressure, which in turn causes decreases the venous return, leading to a decrease in preload and the cardiac output, and can result in hemodynamic compromise if the patient is the preload is not adequate. And it is essential that during VATS surgery, your intrathoracic pressure should be less than 10 centimeters of water in order to minimize the hemodynamic effects. Now, I'm going to just go through certain important concerns of regarding anesthesia management, which are peculiar to video-assisted thoracic surgery. First of all, patient positioning. Now, mostly for all surgeries which are done through VATS, the position is mostly a lateral position is done. Now, if in lateral position, we have to remember that firstly, the pressure point should be adequately padded. And also, the arms, quite often surgeon for putting the ports and to get a good access, they tend to hyper abduct the arms. And then when you hyper abduct, their chances of brachial plexus injuries increase. So you have to be careful that hyper abduction more than 90 degrees should be avoided. Also, you should be careful in positioning your head also. Too much of hyper extension of the head can be detrimental for the patient and can again cause brachial plexus injury and other nerve injuries can be there. So proper positioning of the head and placing the head on certain on supports is essential. Also, because these surgeries are long duration surgeries, DVT prophylaxis using your compression devices should also always be undertaken. Now, with regards to management of one lung ventilation, the principles remain the same. Your target is on one lung ventilation, 6 ml per kg of idle body weight. The ventilation should be there. Your airway pressure should not increase 35 to 40 centimeters of water. And the preferred mode of ventilation is always a pressure control ventilation. Now, how do you deal hypoxemia when your patients are undergoing video-assisted thoracic surgery? The basic principles again remain the same. If the patient develops intraoperative hypoxemia, the first thing is you have to check the position of your double lumen tube, whether it is adequately placed or not. If you confirm that the DLT is adequately placed, then you go to the other steps such as initiating an artificial recruitment maneuver. Or if that also does not suffice, you may apply the PEEP to the ventilated lung and the CPAP lung. Now, application of CPAP to the operative lung is one of the common maneuvers which we use for preventing intraoperative hypoxemia. But here there's a catch. In patients undergoing VATS surgery, if you apply CPAP to the operative lung, it can obstruct the surgical field and the surgeon may not be comfortable while operating. So the best option is you apply PEEP to the ventilated lung, you do an artificial recruitment maneuvers on one lung ventilation to the ventilated lung. If that also not suffice, what you can do is isolation of the selected lung segments in the non-dependent lung, which are remote to the surgical side. You can introduce your bronchoscope. You can the bronchoscope can reach those lung segments which are not involved in the operative side, and you can insufflate oxygen through that. So a selective bronchoscopic guided insufflation of oxygen can be done. Now, during VAT surgery, as I said, that improving lung collapse is very essential. So what maneuvers which we can do to improve the lung collapse? Prior to starting one lung ventilation, you can basically denitrogenate the operative lung by ventilating at a FiO2 of 1 for 3 to 5 minutes prior to OLV. It is that you avoid entrainment of air through the non-ventilated lung. Now you have the DLT port of the non-ventilated lung. So try to keep the port closed, because what happens is the port is open when the during the inspiratory phase, the air is around 130 ml of air per breath goes through the port of the non-ventilated the DLT of the non-ventilated lung, and that can cause insufflation of the non-ventilated lung. So you should ideally close the port at that time. If that also does not suffice, application of suction of -20 centimeter water to the lumen of the DLT, which is going to the non-ventilated lung, can also help. Now, quite often during the course of surgery, the surgeon may ask you to verify the bronchial patency, especially when they are doing lobectomies or they are doing the segmentectomies. The surgeon, before application of his staplers, wants to be sure that he has not taken the normal lung tissue. Now, so what he'll do is he'll apply the stapler. He'll ask you either two things. He'll either ask you to take the patient on 2 lung and inflate the lung, and he'll see whether the normal lung tissue is inflating or is inflating or not, or it's not. Or he may ask you to insert the bronchoscope, and before he applies the stapler, he'll just confirm whether he has clamped the right lung lobe. Here you can see this is the left side, this is the left middle, and this is the left lower lobe. And the surgeon is doing a left lower lobectomy. Now here he has applied the stapler, he has not fired it. And through the bronchoscope, the anesthetist can confirm whether he has the stapler is applied to the diseased part of the lung or not. The another important thing is hemodynamic maintenance. In VAT surgery, always have a large bore IV access, because at any time during the course of surgery, there can be intraoperative bleeding at the time of surgery. There can be, injury. There have been instances there can be injury to the pulmonary artery, injury to the pulmonary vein, and emergency, they may have to open up the patient. Your open chest set should be kept ready. You should have a large bore IV access in both the hands, so that adequate control of hemodynamics can be done in event of a intraoperative hemorrhagic event. Last but not least, the pain management. Now, the pain management, obviously, when patients undergo VAT surgery, the incidence of pain is less as that compared to an open surgery. But still, the pain can be managed using either your intercostal nerve blocks, your serratus anterior block, and with the advent of ultrasound, these two nerve blocks, the serratus anterior plane block and the rectus spinal plane blocks, have become quite popular. Basically, the rectus spinal plane block is just an extension of your paravertebral blocks, and it does give good pain relief in VAT surgery. And it's an upcoming topic for more research. But most of the times, what we have seen in patient undergoing VAT surgeries, the pain can be managed with the local infiltration of the port side and using your commonly used oral non-steroidal anti-inflammatory drugs. And in some cases, an IV PCA pump may be needed. But certain patients, some patients like advanced COPD patients who are undergoing VATS bullectomies, these patients require good pain relief. And in patients with severe COPD. So these are select few patients where we may prefer to insert a thoracic epidural catheter for providing postoperative pain relief. So to summarize, VATS has been shown to decrease postoperative complications as compared to open thoracotomy. There are limited options to treat hypoxemia during VAT surgery. So as CPAP interferes with the surgical exposure, so bronchoscopic insufflation of oxygen can be an option. Priority should be for rapid and complete lung collapse prior to the start of surgery, and this surgery is associated with decreased postoperative analgesic requirement. Now, next, I'll come to the robotic thoracic surgery, just going to the salient features of robotic thoracic surgery. So what is basically the most commonly robotic console, the robotic system which is used is the Da Vinci robotic surgical system, which has been, I think, used over many centers in our country. Now, this has basically 3 main components. There is this is a console in which the surgeon sits and operates, and he looks at the view. This is the patient cart, which has the robotic arms, and this patient cart is docked to the patient. And this is basically a viewing tower in which the assistant can view what the surgeon is doing. So the advantage of robotic surgery is that it basically provides a three-dimensional view of the surgical field, and the robotic arms are basically allows seven ranges of seven directions of movements can be done, which is more than what a human arm can do, and also allows two ranges of axial rotation. Thing in robotic surgery is that the access of the anesthesiologist from the patient is hampered. The anesthesiologist does not have direct access to the patient during a robotic surgery, and this is one of the So what are the advantages of robotic surgery before we go into the anesthesia? The advantage of robotic surgery is it's associated with a short hospital length of stay. It has been shown to show decreased pain, decreased requirement for transfusion, and with minimal scarring and a faster recovery. However, it has certain disadvantages also, because this surgery has an increased learning curve. So initially there may be increased surgical times, and you may require a large number of operating room, increased number of operating room personnel for positioning of the patient, for docking of the robot. So initially that may be requirement. There are chances that in spite of using your all the robotic instruments and all, an end-to-end conversion to an open procedure may be required. And obviously there are the costs involved, because the robotic system is expensive, its instruments and disposables are expensive. The commonly performed procedures using a robotic surgery are thymectomies, mediastinal mass excisions, diaphragmatic repairs like Nessen's fundoplications, esophageal dissection during esophagectomies, and pulmonary lobectomies and segmentectomies are done. Even mediastinal mass, both anterior and posterior mediastinal mass excisions are done through the robotic procedure. Now, what are the certain unique anesthesia implications which I'll be going through? The first thing important is that as in VATS, you need a reliable lung collapse in this surgery. And as I've shown that the anesthesiologist is not in direct access with the patient. So to improve, so it is preferred that we use a left DLT, because it provides with you a greater margin of safety. Because when you insert a right DLT, you have to make sure that your it is aligned with the upper lobe. With left DLT, that's such not a problem. So always go for a left DLT. So I'll be showing you certain figures, and then I'll be telling you what are the anesthesia implications. You'll be able to understand it better. Now, first of all, in robotic surgery is patient positioning. Now, this is a patient which we have taken up for robotic thymectomy. Now, mostly thymectomy procedures are done with the patient is kept supine and he's placed on a beanbag. You can see this is the beanbag, and the patient below the and also we put a lot of number of surgical towels and drapes are put under the patient so that the adequate position is given for the patient. And you can see the arms are by the side of the patient, by the side of the the arms are by the side, and they are also slightly abducted. So in robotic surgery, because both these arms will be by the side of the patient and the anesthesiologist will be having no access, the first and foremost thing is to have large bore IV access in both the arms. Why both the arms? I'll come to that later. All robotic surgeries, because the anesthetist access is not there, mostly like thymectomies or mediastinal mass excisions, always put an arterial, intra-arterial line for monitoring beat-to-beat changes in your blood pressure. Confirm your position of the DLT after positioning of the patient also, because sometimes you can look at this position. The head is so much raised, the body, the thorax is raised by putting on the beanbag. Inadvertently, the tube does get dislodged from its original position. So always confirm the position after you have positioned the patient. Now, another thing in robotic surgery is that you have to have long lengths of your circuits, long lengths of your IV tubings, because the patient is not under your direct access. Now look, now this patient is now positioned near your anesthesia table. Now what surgeons normally do is when they start robotic surgery, first they do a VATS. They do a VATS to have a look at the surgical field, whether it's doable or not. And after they have confirmed that is doable, they put the robotic ports. And after putting the robotic ports, because the Da Vinci, the initial models of the Da Vinci surgical system, you cannot move the patient cart everywhere. So you have to move the patient for the surgery to occur. So what I mean to say is now this patient is now positioned near the anesthesia trolley. Now look, now we have changed the position of the table. Now the head which was near is now positioned towards the window, you can see. Now we have positioned the patient is not rotated 90 degree away from the access of the anesthesiologist. That's why your large length of your anesthesia circuits, large length of your IV tubing is essential, and also putting an intravenous intra-arterial catheter is important. Another thing important during this surgery is that during the course of this surgery, there can be inadvertent injury to the large vessels. We have encountered a situation that the surgeon was doing the surgery, a mediastinal tumor excision, there was injury to the brachiocephalic vein on the right side. And during those initial days, I think I remember I put the intravenous line on the right side only. I had no access on the left side. I had 2 intravenous access on the right side, none on the left side. Now the surgeon told me he has injured the brachiocephalic vein. Then I had, during the intraoperatively, I had to take an access on the left side because the right brachiocephalic vein was injured and he was going to clamp the vein and repair it. So always remember, for robotic, for VAT surgery, always have intravenous access on both the arms, and there should be a large bore access with running fluids. Another practical tip which I would like to give, most of us, what we do when we are giving the infusion of muscle relaxant, we tend to put a relaxant somewhere in the mid, where the extension tubing is joining the normal IV tube, we put in the midway. Always put your relaxants towards the cannula side. Don't put it somewhere in the midway, because then it won't reach adequately. So that is another point which I always tell my PGs that it all will be. Other thing, during the course of surgery, this is a surgeon, he is operating on a mediastinal, on a thymus. Now thymus, when the surgeons do thymectomy, they dissect it over, all the pericardial fat is also removed. So during the course of surgery, they can be intraoperative, mechanical arrhythmias can be there. And in patients who have cardiac compromise, or patients the preload is not adequate, you will encounter hypotension. There are times you have to warn the surgeon when too much of he's dissecting near the heart, and if arrhythmias are occurring intraoperatively, you have to monitor. You have to tell. That's why the insertion of the arterial line is essential. Also, when the surgeon is operating, like for mediastinal tumors, more often, the phrenic nerve is running through the pericardial fat, and injury to the phrenic nerve can be there. And the surgeon, you have to communicate with the surgeon because that is happening or not. Because most commonly what we see in thymectomies are done for patients with myasthenia gravis patients. And if these patients have a phrenic nerve injury, they will definitely have post-operative respiratory compromise. So if such a thing happens, what normally the surgeon does is he does the plication of the diaphragm if a phrenic nerve injury occurs. Another thing that can happen during the course of surgery, especially when they are doing mediastinal tumors, sometimes while doing the surgery, the surgeon, while dissecting the pericardial fat and the tumor, goes high up into the neck, and he may compress on the trachea and your airway pressures may rise. And such situation can commonly occur with large tumors which are extending till the thoracic inlet. Then that time compression of your tracheal airway can be there, and you have to be vigilant that if there's rise in airway pressures or fall in the tidal volume is occurring. So these are certain practical things which do happen. Now, another thing which you have to remember is robot de-docking protocols. It may happen that the patient may bleed a lot and you may have to convert it to open, or some cardiac resuscitation may be needed. You should have your robot de-docking protocols, and simulation exercises should be done beforehand. Docking should not take more than 20 to 30 seconds. The time from de-docking to opening up of the patient should not take much time, and these routines should be practiced all the time. As I said, for VAT surgery, your CO2 insufficiency should not increase 10 to 15, at least 10 centimeters of water. In robotic surgery, it has been seen that the carbon dioxide insufficient changes are more when it's done in the right as compared to the left hemithorax. It causes a decrease in the venous return, decrease the mean arterial blood pressure, causes a rise in the CVP. Also, carbon dioxide insufficient may also cause a rise in the peak airway pressure and decreases the lung compliance. Also, one more important thing is, especially when surgeons are doing mediastinal surgeries, sometimes they tend to open the contralateral lung also, and that can lead to a contralateral capnothorax. And the surgeon will tell you that I have opened the pleura of the opposite side. At that time, you may have difficulty in ventilating the lung which is not being operated. Non-operated lung may be difficulty in ventilation. So at that time, what mostly our surgeons do is they put the ports on the opposite side also, where the lung which is not being operated, and then they take the access from that side, from the opposite side also. Because many a times when they are doing thymectomy surgeries, the surgeon wants the access from the opposite side, which the lung from the opposite hemithorax, which has not, where the lung has not been collapsed, to see whether he is doing a clear surgery or not. So that thing should also be kept in mind, that the surgeon may put his ports on the opposite side also, and that time you may have to alter your ventilation accordingly. Because number of times the surgeon will ask you to give apnea for a brief duration of time so that he can dissect the tumor properly. So these were certain, now this is a patient being positioned for robotic esophagectomy. For robotic or wax esophagectomy, the typical position of the patient is that he's kept in a slightly semi-prone position, and mostly the ports are put a bit posteriorly for dissecting the esophagus. The anesthesia concerns will remain the same: large bore IV access, intra-arterial monitoring. So for all robotic surgeries, that is very essential. To summarize, management of robotic thoracic surgical patients requires knowledge of minimal invasive surgical techniques and familiarity with the robot. Left-sided DLT should be an option for one lung ventilation. Patient positioning and prevention of complications such as nerve or crush injuries is essential. It is important to recognize any hemodynamic effects during CO2 insufflation, and there is potential for conversion to open thoracotomy. Last, coming to anesthesia for lung transplant. So I'll be just running through salient features of lung transplant. And before I begin, obviously, I must confess that I myself have not witnessed any lung transplant. So whatever I'm telling you is what also I've learned from the books. So the lung transplant can be either a lobar transplant, where you just transplant to lobe, or a single lung transplant, a double lung, or a heart lung transplant. Most centers over the world do a double lung transplant. And it has been shown that the median survival rate after lung transplant is approximately 6 years. The chief indications for lung transplant are patients with severe chronic obstructive pulmonary disease and respiratory failure, patients with interstitial lung disease, bronchiectasis. These are the main 3 indications, and also other indications being idiopathic pulmonary artery hypertension and connective tissue disorders. The chief indications worldwide are the major 4 are COPD, cystic fibrosis, interstitial lung disease, and patients with pulmonary hypertension. There are certain contraindications to lung transplant. The absolute contraindication being recent history of malignancy, patient with bleeding diastasis, or patient having any acute medical instability like sepsis or myocardial infarction, and BMI greater than 35. Relative contraindications being class 1 obesity, age greater than 65 years of age, patients with severe malnutrition or osteoporosis. So before coming to the management of recipient, most of for a double lung transplant or a single lung transplant, it's a cadaveric donation. The cadaveric donation can be a brain dead donor, or it can be a beating heart donor. So your management of donor is also very essential. You should make sure that your donor should be, the hemodynamic management should be such that the mean arterial pressure should be greater than 70, heart rate around 60 to 120 beats per minute with a CVP of 6 to 10. Diuretics should be used judiciously so to avoid any fluid accumulation into the lung. You don't want an overloaded lung with fluids for your transplantation. Ventilate the donor lung with using pressure control ventilation with following the same principles, tidal volume of 6 to 8 ml per kg with the adequate PEEP, and preventing any rise in PK pressure greater than 30. Adequate toileting, bronchopulmonary toileting should be done to clear any secretion, and also maintain normothermia, correct any electrolyte imbalances, and appropriate antibiotics to be given. Now, once the lung is harvested, it is perfused with a preservative solution. The most commonly used preservative solution for in lung transplant is Perfadex. This Perfadex is a low potassium dextran containing solution, and which is infused at a temperature of 4 to 8 degrees centigrade. The inflow is through the pulmonary artery, and the outflow is through the left atrium. Now, there is of late some higher centers, especially, have developed a technique known as ex vivo lung perfusion. This technique is used for marginal organs which are marginal, and which you want to use these organs for transplant. And for improving the quality of marginal organs, they use a technique called as ex vivo lung perfusion. Herein, the lung is put in a special shell, and in that shell, you basically put your infuse your preservative solution, and along with that, the lung is ventilated using an anesthesia ventilator with a low tidal volume, and till the time you can improve the quality of this graft. Now, preoperative assessment for a lung transplant recipient. In addition to the routine preoperative assessment, it is important to know what is the underlying etiology for which a lung transplant, whether it's an obstructive etiology, whether it's a restricted lung disease, or whether it's a suppurative pathology like cystic fibrosis. Important to preoperative to know what is the patient's pulmonary artery pressure, because patients with high PA pressure, severe pulmonary artery hypertension may require the use of extracorporeal cardiac life support may be required prior to starting the transplant itself. The VQ scan should be determined, because if you are doing a double lung transplant, it is important to know which lung is the better lung and which lung is the bad lung, because then you can know whether the lung will tolerate PA clamping or not. Baseline ABGs should be done to know the baseline PO2, POCO2, and the pH, and also E for extracorporeal cardiac life support. We'll be putting an arterial line, a central line, a pulmonary artery catheter. The most important monitor is a TE will tell you the preload status of the heart, the right ventricular function, the left. Physiologist can also guide the surgeon to know whether there is any stenosis in the anastomosis, especially when we are doing the pulmonary vein anastomosis. Sometimes stenosis at the level of the pulmonary vein is there, and that the anesthesiologist can tell the surgeon. Also, when the reperfusion of the graft is done, embolism can occur. So that can be detected quite early if you're using a transesophageal echocardiography. The main anesthesia goals during a lung transplant is firstly to avoid any increase in the right ventricular preload. It is important to maintain RV perfusion by avoiding systemic hypotension and any increase in the right ventricular and diastolic pressure. Always maintain a sinus rhythm and positive chronotropy. RV contractility can be augmented using inotropes if and when necessary. Avoid any increase in pulmonary vascular resistance. So you have to avoid hypoxemia, hypercapnia, and acidemia. These should be avoided at all costs. Also, what happens is sometimes during the course of surgery, the patient may, post-induction of anesthesia, patient may develop severe hemodynamic compromise, or patient may have a severe increase in the pulmonary artery pressures. So you should be ready with your ECLS, like your veno bypass or veno arterial bypass should be ready at hand, because you may require to use it at any time. Now, there are anesthesia goals specific to the etiology for which the patient is being operated. In a patient with COPD, these patients may have a dynamic hyperinflation of the lung, and during ventilation, they may develop autopeep. So it is important that these patients should be ventilated with a low tidal volume, allowing a sufficient time for expiration. Patients with cystic fibrosis tend to have thick tenacious secretion. So regular pulmonary toileting may be required for removal of the secretions. Patients with interstitial lung disease may require high ventilatory pressures. So, in these patients, pressure controlled ventilation is needed. And as I told, patients with severe pulmonary hypertension may develop a severe cardiovascular collapse at time of induction of anesthesia itself. So your ECLS equipment should be at hand all the time. So most commonly what's seen intraoperatively is RV dysfunction. So how do we manage RV dysfunction intraoperatively? Firstly, surgical clamping of the pulmonary artery during one lung ventilation will decrease the shunt and improve oxygenation and improve the RV dysfunction. If it does not suffice, use extracorporeal cardiac life support. You can use selective pulmonary vasodilators such as inhaled nitric oxide or prostacyclin to decrease PVR. Catecholamines and phosphodiesterase 1 inhibitors can be used to provide positive inotropy and improve RV contractility. And of late, levosimendan has also been used. The vasoconstrictor of choice is norepinephrine. As I told you, your extracorporeal life support should be ready at hand. Cardiopulmonary bypass nowadays is not routinely used for lung transplant. What is preferred is either a veno-venous or a veno-arterial ECMO. A veno-arterial ECMO is preferred because ECMO requires less amount of heparinization and the blood flows are better maintained. The cardiac compromise is less when you're using a ECMO. Now, what happens at the time of organ perfusion? Now, if you are doing a double lung transplant, what happens is when you reperfuse the organ, the allograft should be reperfused slowly over a period of 5 to 10 minutes. the organ which is being reperfused first, the lung which is transplanted first, you do gentle alveolar recruitment and ventilate with a limited, you limit the peak airway pressures to less than 30, use a PEEP of 5 to 10 with the FiO2 of less than 40. Whereas the native lung is ventilated with a high FiO2, while the new allograft is reperfused and protected. So you may require a double lung ventilation. You may need 2 ventilators because the native lung you'll be ventilating with a high FiO2 till the time you remove the native lung and the new graft. Whereas the lung, which is the graft which comes first, should be ventilated using a protective lung ventilation. Now, commonly seen at the time of reperfusion is ischemia-reperfusion injury. In lung transplant, the ischemia-reperfusion injury presents with hypoxemia, decrease in the lung compliance, increase in the pulmonary presence of pulmonary hypertension, pulmonary edema. In the advent of a severe cardiac compromise occurring during the time of reperfusion, ECLS again has to be present. It should be present standard because severe primary graft dysfunction has to be managed using extracorporeal life support. Inhaled nitric oxide can be used to improve oxygenation, but it has been shown to be of less benefit. Sorry. Post-operative analgesia, various techniques have been used, use of non-opioid analgesics, IV PCA pumps with low-dose IV ketamines. Even regional techniques have been used in recipients such as use of epidural and paravertebral analgesia. Post-operative care, after single lung transplant, early extubation is feasible, but in patients undergoing double lung transplant may require some brief period of protective lung ventilation of PA pressures and peak airway pressures, lung airway pressures also. If prolonged ventilation is anticipated, tracheostomy should be done. Early complications after lung transplant are primary graft dysfunction, hemorrhage, surgical anastomotic anomalies, and cardiac dysrhythmia. Late complications include chronic rejection, renal dysfunction, and malignancy. To summarize, pre-operative assessment is paramount for planning intraoperative strategies during lung transplant. Careful anesthesia induction is essential to avoid cardiovascular collapse. TE is an invaluable intraoperative tool, and perioperative ECMO support is beneficial for patients, and reduction in early post-operative complications confirms a long-term survival benefit. Thank you.
I thank Nitin for giving us such a vast, topics knowledge in such a short time by covering all the advanced thoracic surgeries, anesthesia with all practical points. Really, it's amazing that you have covered such a vast topic in such a short time. Question answer session will be after all the talks. So I request now second speaker to share the screen. She's Dr. Shikha. She's also senior consultant at Gangaram Hospital. Her special interest is also thoracic anesthesia. She is also author of the book, an edited book of clinical thoracic anesthesia. She has many national and international publications in her credit, and she's going to tell us about anesthesia for advanced endobronchial procedures. Endobronchial procedures are also, going to be the challenging task for us, and we need the skilled anesthesiologist for dealing such kind of the cases. So I request Shikha to share the screen, and please go ahead. Dr. Shikha. Dr. Shikha.
Yes, is it available, ma'am, the screen?
Yeah, I can see your slide.
Yeah, so should I start?
Yeah, please start.
Okay. Good evening, everyone. So I'll be talking about anesthesia for advanced endobronchial procedures. And before we talk about the advanced endobronchial procedures, let us first summarize the challenges which we face in the bronchoscopy suite.
Excuse me.
Your slides are not moving.
Can you go to the slideshow?
Yeah. So, interventional pulmonology is a specialty which deals with minimally invasive endoscopic and percutaneous procedures for the diagnosis and treatment of both neoplastic and non-neoplastic diseases of the airway, lungs, and the pleura. Interventional bronchoscopy can be done either for diagnostic or for therapeutic purposes. It could be a transbronchial needle aspiration, a transbronchial lung biopsy, or endobronchial lung biopsy, or a navigational bronchoscopy, or autofluorescence bronchoscopy. The therapeutic procedures could be for tumor debulking using a laser or electrocautery, cryotherapy, phototherapy, or brachytherapy for giving targeted therapy to the carcinoma cells. A rigid bronchoscopy could be used for removing a foreign body, and in cases of tracheal stenosis, a balloon dilatation, using a balloon dilatation device, or even a stent placement, which could be either silicone or metallic stent, dilatation of the tracheostomy, and the newer procedures like the therapeutic bronchoscopy for emphysema and asthma, using lung volume reduction surgery or a special valve, which is a one-way valve, or bronchial thermoplasty for severe asthma cases not responding to the normal pharmacological treatment. The challenge we face in the bronchoscopy suite is that we share the airway with the pulmonologist, and this is compounded by the severity of the lung pathology and other comorbidities which the patient may be presenting with. So we need to be familiar with the planned procedure and need to develop an anesthetic and airway management plan for the procedure. But having said this, the procedure itself is dynamic in nature, in the sense that sometimes the bronchoscopist needs a change in the airway device or mechanism which we are using. A fraction of inspired air oxygen may have to be changed, or even the ventilation mode has to be changed as we go along, depending. So we have to think on our feet and be prepared for plan B, C, etc. And be prepared for everything, because it can be a very dynamic procedure, although we may think that it is a procedure for doing, say, a tumor debulking, but sometimes the tumor may get dislodged and then you have to think of something else to remove it. So, as with all surgeries, preoperative assessment and optimization is half the work done, and a proper preoperative assessment and optimization gives a better intraoperative and postoperative outcome. Evaluation is as per the ASA guidelines. We have to focus on procedure-related individualized risk assessment and optimization. And the laboratory testing should also be individualized and focus on the relevant testing only. Airway assessment is very surgical procedures. We need to, in airway evaluation, we need to know the symptoms of the compromise, whether there is any compression, say with the interior mediastinal mass, if the patient is have dyspnea on lying down, the size of the lesion and the tumor, its extent or location, a prior treatment which may affect other organs of the body, have all to be kept in mind and taken note of. Basic diagnostic procedures happening in the bronchoscopy room usually do not require us, and they are done under local anesthesia. Very rarely, if the patient has other comorbidities, then sedation or general anesthesia may be required. For advanced diagnostic procedures like biopsies, monitored anesthesia care with TIVA or general anesthesia may be required. And with advanced therapeutic procedures, we can use either a flexible or a rigid bronchoscope. General anesthesia is usually required, and a supraglottic airway device, endotracheal tube, rigid bronchoscope are all our airway equipment which we may require in these procedures. So as I said, the basic bronchoscopy procedures are performed under minimal or moderate anesthesia, while the advanced diagnostic and therapeutic procedures require deep sedation or even general anesthesia. Pre-medication is usually not required in these patients, because if we give some and with the patient already having a respiratory compromise, there may be an increased risk of hemodynamic changes. So sedatives, etc., are only given if the patient is too anxious. Otherwise, giving of sedations can also hamper the respiratory drive of the patient. Intraoperative conditions, the topical anesthesia and sedation could be used in some of these procedures. GA is required in most advanced procedures, and total intravenous anesthesia is a better technique, and muscle relaxant is rarely required and only required if it is absolutely necessary, as in placing a stent or removing of a stent. These kind of procedures would require a muscle relaxant because a moving patient can be catastrophic in these situations. The cornerstone of total intravenous anesthesia is propofol infusion, which we commonly use in our center. Inhalational anesthetics, fentanyl, midazolam and fentanyl, ketamine, dexmedetomidine are all other adjuvants which we can use in these procedures. The advantage of TIVA is that it avoids polluting the operating room with the inhaled anesthetics, and it ensures the continuous delivery of anesthesia despite the possible ventilation leaks, and it allows utilization of intermittent apnea or gent ventilation techniques as and when required. Also, since we are sharing the airway with the bronchoscopist, we are really not sure of how much of the inhaled anesthetics is reaching the patient and if we are able to achieve the MAC concentration. So TIVA gives us a better control and ensures the adequate depth of anesthesia. The choice of airway for subglottic and upper tracheal lesions is the supraglottic airway device, in which we prefer the iGel because it does not have a preformed shape and it is easier to pass a bronchoscope through this. For lower tracheal and bronchial lesions or defects, we should, if we are planning to intubate the patient, we should use a tube as large as possible to allow room for the bronchoscope and also a simultaneous ventilation. Other equipment which we find useful in the bronchoscopy suite is a swivel connector, which allows continuous ventilation without having to disconnect the circuit. Ventilating rigid bronchoscope, intermittent apnea, and jet ventilation are other modalities of ventilation which become handy in the bronchoscopy suite. Use of muscle relaxant is really not preferred and has very specific indications. Although it would facilitate the insertion of an LMA or endotracheal tube, it is absolutely necessary when we are doing a procedure under rigid bronchoscope. It improves the overall lung compliance by eliminating the chest wall component, and it provides a motionless patient, which is advantageous when unexpected movement of patients can result in grave consequences. The often neglected point in bronchoscopy surgery is fluid management. And it is wise to restrict all administered fluid to minimum because many patients present with the limited lung reserve and pulmonary congestion may aggravate this condition. The patient may have a right heart failure due to a pre-existing cohort pulmonary, and therefore we need to be very miserly on the fluid we give to the patient. Most of the procedures are carried out by administering 100% of FiO2, but it is usually necessary to maintain it at the lowest tolerable level, especially when we are using lasers, as they can cause airway fire. And then we have to take the FiO2 to less than 40%. So if the patients cannot tolerate the lower levels of oxygen, then it may become necessary to defer the treatment temporarily or to ventilate at higher oxygen concentrations or use apnea or even jet ventilation techniques if feasible. There is no evidence for any real advantage for the use of steroids in bronchoscopic surgery, but airway edema is caused because of the use of flexible bronchoscope, which is taken in and out of the airway several times. A rigid bronchoscope, by its very nature and robustness, may cause swelling at the vocal cords, and extensive tracheobronchial tissue trauma can be caused by prolonged procedures. So even if there is no real advantage, we usually prefer to give steroids in all these patients. Coming to the anesthesia technique for advantages are usually carried out under general anesthesia with using either a supraglottic airway device, an endotracheal tube, or using a rigid bronchoscopy with ventilation by the side of the rigid bronchoscope. The anesthesia is maintained using total intravenous anesthesia. And when we are giving a total intravenous anesthesia, we need to remember that the integrity of the IV access is very important, because our anesthesia is only through the IV line, since we cannot rely on the inhaled gases. And for monitoring, this is very important, because we should know that to be able to assess the depth of anesthesia or the adequacy of anesthesia, this is a very important and useful monitor. Coming to specific anesthesia consideration for specific procedures, for endobronchial transbronchial needle aspiration, this is usually carried out using a flexible bronchoscope. This can be done under moderate sedation, but usually done under total intravenous anesthesia. A linear or a radial probe is used, depending on from where the biopsy needs to be taken. We usually use an eye gel, and the patient is discharged home post-procedure on the same day. Electromagnetic navigational bronchoscopy. This is the biopsy of the periphery of the lung distal to the bronchoscopic reach. In this, the sensor probe navigates the bronchial tree, and a computer converts the CT scans into a 3D diagram of your bed. The airway of choice is an eye gel, and the anesthesia of choice is total intravenous anesthesia. Tumor is an important procedure and a very common procedure being done in the bronchoscopic suite. This can be done using a laser. Short wavelength laser of the laser coagulates, while the longer wavelength resects by evaporation. Nd:YAG laser is commonly used. We use a flexible bronchoscope, but it can be done using a rigid bronchoscope also. There is also carbon dioxide laser, but it is very cumbersome, has a big machine, and it is used only for above carina or around the larynx, but we do not use it. The risk with this is the risk of airway fire. The FiO2 has to be less than 40%. And if you think of intubating the patient, then these require a specialized endotracheal tube, which have a covering which are not affected by the laser. So to get a FiO2 of less than 40%, sometimes we use air as the gas to ventilate these patients after initial ventilation with 100% oxygen. And the airway of choice would again be the eye gel. Endobronchial electrocautery and the voltage. The risk with this is that it interferes with implantable deafening. The airway and the anesthesia technique is the same: eye gel, flexible bronchoscope, and TIVA. Iron plasma cautery, it has less depth of penetration, and it is useful for superficial lesions, just like something like when there is a granulation, argon plasma cautery is used. And the advantage is that it can be used near stents, and it can be used for lesions which are a bit far off. The risks are the same, like in electromagnetic interference, air embolism. It is again by using the flexible bronchoscope, passing through the eye gel, and TIVA. Delayed resection techniques, these are usually palliative techniques using cryotherapy, which has a freezing or a thawing cycle using liquid nitrogen these days instead of nitrous oxide. It can be used even to take biopsies or to remove small tissues areas. The principle of this is that it freezes tissues which are high in oxygen, so it will not act on tissues, say cartilages, which have high in water content, and it will not freeze tissues such as cartilages which have low water content. Brachytherapy and photodynamic therapy using porphymer sodium are other resection techniques, but these are usually palliative techniques. To the main cornerstone of anesthesia, vigilance and close communication with the pulmonologist is very important. We have to make constant adjustment to optimize oxygenation and ventilation. And must be aware of the complications like hemorrhage, airway rupture, and airway fire when using a cautery or a laser. Airway hemorrhage is commonly encountered and is a dreaded complication. It is defined as 100 to 1000 ml of blood loss over 24 hours. The problem with the patient occurs due to image, and it is more life-threatening than the blood loss itself. Therapeutic bronchoscopy has higher risk of bleeding, transbronchial lung biopsy, because we cannot see the distal end of the tissue we are dissecting. So we could be encountering a hypervascular tumor or even vascular abnormalities at the other end of the tumor or the granulation tissue which we are attempting to resect or remove. Airway hemorrhage is most likely the cause of death by asphyxiation rather than by blood loss. We need to protect the non-bleeding lung so that the patient, for this, the patient should be placed in bleeding side down and the airway secured with a large endotracheal tube, either in the trachea or in the bronchus, which is not bleeding, or even a bronchial blocker can be used. We do not use a double lumen tube routinely because then we can, due to the small lumen of the tube, we cannot pass the therapeutic bronchoscope through it. So double lumen tube can only be used if we are unable to control the hemorrhage and we plan to take up the patient for surgery. And once we have blocked with the bronchial blocker or intubated the non-bleeding side, then we may try to control the airway hemorrhage with either a flexible or a rigid bronchoscope as may be possible. But if we have intubated, we can only use a flexible bronchoscope and not the rigid bronchoscope. So proximal areas which can bleed may be the trachea, the mainstem bronchus, and proximal lobar bronchus. And there may be sometimes distal bleeding. The small bleedings are usually controlled by using the balloon tamponade, ice, saline lavage, topical laser, and electrocautery. Coming to another common situation in which we are called is a tracheal stenosis. And in these patients, the dilatation of the stenotic segment is carried out by a balloon, and this is known as a blasty. It requires repeated attempts and sometimes, more often than not, is combined with stenting. The balloon is inflated to a particular pressure and the pressure is maintained for around 45 seconds. The risks are airway rupture, especially if the airway has previously received any chemotherapy, hemorrhage, acute bronchospasm, tracheitis, and pneumotherapy, hemorrhage, acute bronchospasm, tracheitis, and pneumomediastinum if there is injury to the airway stenting is used for airway stenosis, and the indications could be either malignant or benign, or even the presence of airway fistulas. Malignant could be primary lung cancer, thyroid colostomy, post-lung transplant, tuberculosis, granulomatosis. Airway stents are usually used in combination with balloon dilatation, electrocautery coagulation if there is a granulation tissue which is causing the stenosis. Silicone stents are commonly used because they can be modified by cutting a part to customize the anatomy. They have ease of placement, adjustment, and removal. They have low rate of trauma and perforation. The design of the tube is such that it prevents the tumor growth into it. It is easier to remove and is safe. Metal stents, however, have a tendency of granuloma growth into the stents, and they are usually used for malignant or palliative situations using a flexible bronchoscope. The disadvantage of silicone stent is that since it is smooth, the stent is smooth, although it has these buttons which get into the tissue, but still there is a higher rate of stent migration, and due to it having no holes, it blocks the normal bronchial wall mucociliary function. The common silicone stents may be the Montgomery tube, the tubular stent, or the wire stent, which can be used for trachea and dilatation of the tracheobronchial tree if the stenosis is a long one extending into the bronchus. Expanding metal stent is used usually in cases which are malignant and which are not amenable to surgery. They are compacted reducer. General anesthesia using a flexible bronchoscope is used. Rigid bronchoscope gives a snug fit, but it causes rapid epithelialization happens. It has a lower migration rate. Adjustment and removal is very difficult. So if you inflate it at a wrong place, then it would be very difficult to reposition it, and it has a very high rate of trauma. A flexible bronchoscope with supraglottic airway device or large bore endotracheal tube can be used. Rigid bronchoscopy using jet ventilation or ventilation through bronchoscope are the airway management techniques which we can use for stents. In presence of fistula and airway dehiscence, it is important to maintain spontaneous ventilation because otherwise, if we give positive pressure ventilation, the air may egress either into the mediastinum or into, if it is a tracheoesophageal fistula, into the stomach. So spontaneous ventilation is maintained using dexmedetomidine, inhalational anesthetics, and even local spray as we go along. The newer devices for which are very exciting are lung volume reduction valves. These valves are indicated in emphysema, alveolar pleural fistula, and bronchopleural fistula. These are one-way valves, and this can be placed in the segmental or subsegmental bronchi. They allow passive exhalation and secretion clearance, and they prevent, and since they are one-way valves, they prevent air to preferentially go into the these emphysematous areas. So the placement of this improves the cardiac and diaphragm function, and it helps in the recruitment of the compressed alveoli. General anesthesia with endotracheal tube is preferred. Since most of these patients have respiratory distress, anesthesia may be induced in a recumbent position, and ventilation setting may require a longer exhalation time. Coming to bronchial thermoplasty, this is a new technique which is used for asthmatic patients who do not respond to normal pharmacological treatment. This is carried out in 2 sessions, 3 weeks apart. First session is involving both lower lobes, and the second session is both upper lobes of both the lungs. It applies a radiofrequency energy to the airway valve, generating a temperature of 65 degrees centigrade. This reduces the smooth muscle mass, but avoids tissue destruction and searing. And with this, what happens is the capillaries, the nerve endings, the mucosa, they all regenerate. Muscle cannot regenerate and is replaced by fibrous tissue. And so the narrowing of the airway due to any stimulus does not happen, and thereby the patient may have an improvement in his asthma status. So to summarize, the bronchoscopic surgery is evolving. The anesthesiologists need to stay up to date with the new procedures as we share the airway with the pulmonologist, to tailor and modify old anesthesia techniques and develop new ones to meet the new needs, and effective communication and teamwork for successful management of these challenging cases. Thank you.
Thank you, Shikha, for telling us about the anesthesia for endobronchial procedures. The question answer will be at the end. In the era of life-threatening chest injuries are the common and leading cause of morbidity and mortality. To give anesthesia for such kind of the patients is a real challenge for all of us. We know that. For this topic, I invite Dr. Urvi Desai. She's the youngest speaker of the day from the glamorous city of Mumbai. And I'm sure that she's going to tell us nicely about this topic. Dr. Urvi, you can share your screen.
Yeah. Okay.
Yes,
Good evening,
could
everyone. I think the first two lectures were really advanced and nicely said. My lecture is a little basic. I'm Dr. Urvi Desai, Associate Professor from Sion Hospital.
you have to go ahead with your. Yes,
Can you see
we
my
can.
slides? Can I go ahead?
Yes, you can go ahead.
Are we seeing the slides?
Yes, we can.
Okay, thank you. So chest trauma, we know that there are two, it's either blunt or penetrating injuries causing chest trauma. Blunt trauma, usually what we see in our institute are mainly because of road traffic accidents, motor vehicular accidents, blast injuries, and fall from height. And penetrating trauma to the chest are mainly from gunshots and stabs. The interesting point is that our thorax is semi-rigid and it's kind of protective. It protects all our vital organs, our heart, our lungs, our great vessels. And even though is responsible for 25 to 50% of mortality of all traumatic deaths, the main treatment or management is usually conservative. All it requires is an ICD insertion and oxygen therapy. Just maybe 10% of the total blunt chest trauma requires surgical intervention, and 15 to 30% of the penetrating trauma requires surgical intervention. So main thing here is that our primary and secondary survey, the time when the patient enters the ATLS guidelines tells us the A, B, C, D, E needs to be started immediately, because that's the crux. That is what is going to save our patient. That is what is going to, decrease the mortality, because in our primary survey and in our resuscitation of the vital functions, are we going to find out the 6 life-threatening injuries which are there with chest trauma. They are the airway obstruction, tension pneumothorax, open pneumothorax, massive hemothorax, flail chest, and cardiac tamponade. Now, when the patient comes to our emergency department for various reasons, he could be obtunded, his airway could be obstructed because of vomitus, blood, edema, and we have to take charge and take control and put in a tube. That is one thing that we need to sort out immediately. Second thing that we need to sort out and look for is tension pneumothorax. So when to the emergency area, the entire team starts working. There's somebody putting the oxygen, the vitals are being taken, the monitors are being attached. We have to, as far as possible, start the fluid, start the inotropes. And when we see that on the X-ray chest, there is a tension pneumothorax, it becomes pertinent to immediately treat that patient, because it's going to lead to cardiac arrest. We need to put in a chest tube immediately in the 5th intercostal space, just anterior to the mid-axillary line. If we don't have a chest tube ready, if the surgeon is doing something else, okay, we go ahead with a needle decompression that is in the 2nd intercostal space, the mid-clavicular line. Many times the patient do come in with a large defect in the chest, and they may have an open pneumothorax, that is a sucking kind of a wound. Now, this also behaves like a tension pneumothorax. We need to address it immediately. We put an occlusive dressing, which is closed on 3 sides but open on the other. I'm sorry. What is happening with them? Okay. Now, as we go ahead, as we stabilize a patient, we look into, we start doing the secondary survey. In the secondary survey, when the patient is stable, we can send the patient for CT scan and look out for potential life threats. Now, what are the potential life threats? A simple pneumothorax, a simple hemothorax. Sometimes what happens, the patient's GCS is very poor and we immediately intubate the patient, but we have missed out on a simple pneumothorax, which can become a tension pneumothorax, contusion, lung contusion, aortic disruptions, tracheobronchial injuries, diaphragmatic and esophageal rupture. What what we can understand is that the thoracic trauma is not static. It is dynamic. It's continuously changing. A patient may be wheeled in, maybe having vitals which are normal, maybe having a GCS which are normal, but in 2-3 minutes, we may be seeing, oh my God, the patient has arrested. So there is a need for continuous assessment and reassessment. Physiologically, in chest trauma, there is disruption of either respiration or circulation. So what happens is in the respiration, the respiratory mechanics are usually affected with the thoracic cage deformity. In rib fractures, there is direct injury to the lung, there is contusions, there's VQ mismatch, there's shunting, and hypoxia. Hypoxia is the most serious consequence of chest injury, and we have to, at all times, prevent it and correct it. Another disruption which is happening in chest trauma is circulation. There's an obstructive kind of circulation happening in cardiac tamponade and in tension pneumothorax. And many times when there is direct injury to the heart and to the vessels, there may be a hemorrhaging shock. To my gate over here, and when you enter the right is my 14-bedded ICU. Okay, and as we see that there is a receiving area, the patient is in the trolley, we receive here. This is my team working, trying to stabilize, sending labs, attaching monitors, oxygen, trying to do a perfect primary survey. So we pick up the life-threatening injuries. And then when the patient is slightly stable, or when we have decided, no, this patient can go for CT, or this patient needs to go to ICU for further management, or this patient needs to be wheeled into the OT directly. So in my hospital, in the last 1 year, we had 1,500 trauma admissions. We had chest trauma around 100. The maximum number of cases were due to the road traffic accident, and they were blunt chest injury and fall from height. If you see the maximum number of blunt chest injury, there was rib fractures causing hemothorax, pneumothorax, and then a lesser and lesser flail chest, lung contusions, tracheobronchial injuries, etc. Penetrating injuries were very few. It may be because of COVID effect, because in the last 6 months, the admissions have dropped down. And mind you, in June, July, and August, the admissions were just 50, 60 rather than 180 to 200 per month. Penetrating injuries are, it's very easy to stab somebody in the neck. It's very easy to stab somebody in the abdomen, but it's very difficult to stab someone in the, on the chest wall. So we don't get that many anterior penetrating chest injuries. Gunshots, I must say that patients usually succumb at the scene itself. So I personally haven't seen any gunshots in the chest coming to a hospital alive. There may be gunshots to the head, self-inflicted, but gunshots to the chest are rare. This study was done by Stefan Heber in Germany, and it was a very large study of 22,000 patients. And what he concluded was that mortality was maximum when patients came with bilateral lung contusion, bilateral flail chest, by a major thoracic vessel injury and direct injury to the heart. Obviously, the mortality was further increasing with age, hypotension, and blood transfusion, and the rib and the chest wall injuries did not cause that much mortality. He also, if you see, when we look at the audit, it is similar to my audit in the ICU, where there were maximum number of rib fractures, pneumothorax, hemothorax, and lung contusions. So as an anesthesiologist, what is our role? Our role, we play a very important role as a team member in the emergency department. Actually, we can even be the leader in the emergency department. We have a very crucial role to perform in the primary survey and resuscitation following the ABCDE guidelines of the ATLS, because it is that moment or that time that we can save the patient and catch the life-threatening injury and go ahead with the decision of surgery or conservative management. We are extremely skilled in our airway, and our role comes in securing the airway and ventilatory management. I think ICD insertions we can learn easily, not a big deal. We are there to optimize the patient, to stabilize, and also make a decision that now is the time to take the patient in the operation theater. We are providers of anesthesia for chest injury surgery in the operation theater, pain management, and post-op care. I have 1 or 2 cases which we can discuss. This was a gentleman who came with a fall on the aluminum rod. He was working in a handloom factory. He came, if you see the ABCDE, he came with a normal GCS. He had normal vitals, but his air entry was decreased. and he was desaturating. We did an X-ray, and what the X-ray showed was a hemothorax. Immediately oxygen was given, chest tube inserted, 1000 ml drain. He was resuscitated well, and he was sent to the ward. But what happened then was he came back again gasping. This was an X-ray after treatment. Okay. Now he came back again gasping in 2 days, and we saw he was a whiteout shadow. He had a retained hemothorax, pneumothorax on the CT scan. He needed to be resuscitated with blood and blood products, everything, and it was decided that we do a left thoracotomy under GA with clot evacuation. Anesthetic goes, if you see, he has a very difficult airway. We had to perform an awake fiber optic. He had deranged coagulopathy. We could not put in an epidural. Stable patient, so we did a routine induction, and he was all well post-op. Now, the intercostal nerve block was given to him and fentanyl patch. We could not extubate him because the lung had not opened well intraoperatively, but extubated after 24 hours. So massive hemothorax. When do we wheel in a patient? When it is draining, when the chest tube is draining more than 1,500 ml in 24 hours or more than 200 ml per hour for about 4 hours. That is the time we need to wheel in the patient. He may be very hemodynamically unstable. We have to go slow in our anesthesia drugs. We have to give it very in a titrated manner. And sometimes we may have to isolate the lung isolation of the patient may be required immediately to prevent the contamination of the other lung, which can be given either by WMIN, bronchial blocker, or best is in the emergency hour, in the wee hours in the morning, the anesthetist who is there may or may not be trained with the DLT or bronchial blocker, but an endobronchial tube is best. Is best at that time for lung isolation. Now, the massive hemothorax may be caused because of lung laceration, intercostal injury, and maybe great vessel injury or cardiac chamber injury. Therefore, the patient has to be wheeled in and done a thoracotomy to check out whether any of these things are there and to control the bleeding immediately. Sometimes what happens by the time you're preparing this patient in the OT, the patient exsanguinates right there, and we may witness a cardiac arrest. What do we do at that time? Then there is something called as an emergency thoracotomy. What is that? That without taking the patient in the OT, right there in the emergency department, the surgeon decides to snip and cut the thorax bilaterally open. And this is usually done to control the hemorrhage, to give an internal cardiac massage, to release the pericardial tamponade, and directly cross-clamp the descending thoracic aorta to stop the bleeding. Obviously, the survival rate is quite poor, maybe 5%, but if you see the Western literature, their survival rate is from 50 to 60 to 70%. So they are going ahead with this. The next case I want to discuss is this young transgender who came in, as you can see, with a screwdriver driven right into the center of the heart. He was little upturned. His GCS was poor, his pulsations were weak, his BP was not palpable. His department, we had to start all the fluids and ionotropes, but he was still, he was deteriorating. X-ray chest, we could not do anything else except for X-ray chest and probably the fast. And then we realized that this patient has to be wheeled into the CVTS OT immediately, giving very small doses of anesthesia with a sternotomy, and it was done with a beating heart. You can see that screwdriver was in situ. We did not remove it, and while they were taking a purse string, that's the time it slipped out and there was gush, blood. Again, we had to do aggressive resuscitation to the patient, but patient was young. He survived. We gave there was blood loss around 2.5 liters. Blood and blood products were given. He was extubated on table, and he was given pain relief with fentanyl patch and wound infiltration. So penetrating cardiac injury, I would like to say that they're very fatal, and less than 5% reach the hospital. If you see gunshot injuries, as I mentioned, more than 80% have things, they do have a survival, and only 20% mortality is there. Many times the penetrating cardiac injury, the weapon may not go into the heart, but it may cause a cardiac tamponade. So how do we see that? Immediately we have to look for the Beck's classical triad of distended neck veins, hypertension, and muffled sounds. Muffled sounds, I think it's a little difficult in a noisy ICU. So what do we depend on? We depend on an echocardiography, we depend on the fast, and we depend on the X-ray chest. X-ray chest may show a globular pericardial, a globular cardiac shadow. As little as 50 ml in the pericardium can cause a cardiac tamponade. And what do we do? The only way that this patient can survive is pericardiocentesis, but that is again a diagnostic tap. Remember that cardiac tempo, we have to keep the fluid running and we have to keep the heart rate up. So start the fluid resuscitation and start the inotropic support as soon as possible whenever you diagnose this patient and wheel the patient in for a thoracotomy and open. As I mentioned in my case, we did not require CP bypass. So many times penetrating cardiac injuries can be done without CP bypass, but sometimes septal lacerations and pulmonary artery lacerations require cardiopulmonary bypass. Scenario which I wanted to discuss because this was the backstab. Again, mind you, this was a young patient. All our young patients come out very well. What happened to this patient? If you look at the size of that weapon, it went right. It was a backstab, and it went right through the vertebra 7, and the patient, and it transected the spinal cord, and patient came with paraplegia. However, we did a good resuscitation in the emergency area, and patient's vitals and GCS was good. We could shift him to the CT scan, and what we saw was the tip of that sword was just 1 centimeter from the heart and the pulmonary vein. So everybody was the entire team was over there, the neurosurgeons. We had called the cardiovascular team also, because while retrieving the weapon, there could be a chance of injury to the heart and the great vessels. Initially, it was decided to do a thoracotomy and 1 lung, but I think the surgeons got little confident and they decided to put the patient in the prone position. Everything went smooth. The weapon came out nicely. There was no injury. Patient was, I think, God's grace. What would have happened in the prone position if there would have been a damage to the heart or the great vessels? Okay, now an injury, anybody can guess what this is? Yeah, if you look at the X-ray, there's a widened mediastinum. If you look at the CT scans, yeah, there's aortic dissection. So it's aortic injury. Now, aortic injury, let me tell you that it's a injury caused by rapid deceleration, so high vehicular collisions and high velocity accidents, right? But we don't encounter that many nowadays. Why? Because we are all wearing our seat belts and we are all having our airbags when there's a collision. Half the patients die after coming to the emergency area. And the thing to remember is that this rapid deceleration usually happens at the point distal to the left subclavian artery, because that's the point. The heart and the arch of aorta are mobile, and the descending thoracic aorta is not so mobile. And that is where the shear stress takes place and there's a tear and the injury. Now, the definitive diagnosis is CT because patient may come normal. The hematoma is contained by the mediastinum and the pleura. Or sometimes the patient may come with a stroke, or the patient may come with unequal pulsation. So we kind of miss this aortic injury. But how do we make sure that we have a high suspicion of this injury? That when you have the first, second, and third rib fractured, then you should keep in mind that there could be a chance of the aortic injury also. Now, what is the treatment? Usually you go for open repair or endoluminal repair. Open repair, so we know that there's going to be high chance of bleeding, and again, mortality is up to 28%, high chance of paraplegia. So the in thing right now is the endovascular stenting and endovascular luminal repair, which is there, I think, in the next lecture in detail. So most of the times this aortic injury repair can be done without CP bypass, just by doing a left thoracotomy and 1 lung ventilation. But if the very proximal part of the aorta is involved, then a CP bypass may be necessary. And next important injury that we have to keep in mind, that is when we are doing a secondary survey, is a tracheobronchial injury, which can be caused both by blunt or penetrating. Now, the thing over here, the incidence of lower intrathoracic tracheobronchial injury is very less. It's less than 1/7. Most of the time, it is the upper airways injury which has happened. So how do we have a suspicion that the tracheobronchial injury is there? Is that these patients will have lot of subacute emphysema. Patient may be having hemoptysis, stridor, and hoarseness, but after, and they usually have hemo and pneumothorax pneumothorax. So when we put in an ICD and it's too large, it's a very, very large leak, then I will suspect that yes, this patient may be having a tracheobronchial injury, or if the patient is having sternal fractures or upper 1 to 3 rib fractures, then yes, he must be having a tracheobronchial injury, and its diagnosis is again not based on X-ray. It's based on CT scan. Now, the important goal in this tracheobronchial injury is the definitive airway sometimes may be tricky. The patient may require fiber optic bronchoscopy, and that is anesthesia. Either we do it awake fiber spontaneous, but the thing to remember is that these patients also require a one lung ventilation and thoracotomy approach. Now, to put in a DLT in a tracheobronchial injury is very difficult, because DLTs are difficult to insert, and they are very difficult to insert when the trachea bronchia is injured. So what are the other options? Bronchial blocker can be used, or endobronchial tube. Now, this fellow in Snehal has given a very good case report in this article, where he has also used something called as a cross-field ventilation technique. What he has shown over here is that the tube is first passed through with the help of fiber optic, and then one lung ventilation given, and the repair of the tear has started, and then intraoperatively is withdrawn the tube slightly, and surgically another tube is passed into the bronchus of the ventilating lung, and the entire tear of the trachea bronchus is sutured. But I think we require a lot of expertise before we go ahead with that. Now, this is another study which was done by Kumar, in that he studied was a traumatic airway injuries can be by both blunt as well as penetrating trauma, but those which are caused by the blunt trauma are having higher mortality compared to the penetrating trauma. Now, coming to our next injury, that is the blunt cardiac injury. Many times, this is usually seen again in high traffic accidents or in sports injury. A certain blow to the precordium causes a damage to the heart, and this is comatico-cordis. It causes an arrest rhythm, a ventricular fibrillation rhythm. Actually, there's no structural damage to the heart. It usually happens because there is in a particular cardiac cycle, RNT phenomena happens, and the patient goes into fibrillation. And we all know this guy, Bruce Lee, and we know his Chinese martial art, Dim Mak, the touch of that. It depends. It's anesthetic. When do we suspect cardiac injury? When we attach the ECG and there is arrhythmia, keep in mind that this patient may be having a cardiac contusion, and we have to monitor him for 24 to 48 hours. He may have the worst spectrum. He may come with cardiogenic shock. He may come with free wall or septal wall rupture, or even coronary artery thrombosis simulating an MI. Most of the time, the right ventricle and the septum is involved. If there is a myocardial rupture, then yes, patient requires a CP bypass for it to be repaired. Now, this can be caused both by penetrating and blunt. It is very difficult to assess a diaphragmatic rupture on primary or secondary survey. Most of the times it is missed, and many times it is picked up when we are exploring the patient for some abdominal surgery, like a liver lesion or a spleen lesion, and then we realize, oh my God, this patient has a diaphragmatic tear also. So if it is missed, it becomes very difficult, because then hernia, only if the X-ray is so nice as this, where the entire we can see the entire gut and the stomach into the thoracic cavity, pushing everything on the right side, then it is easy to pick up a diaphragmatic rupture. The hernia, if we miss it, then it can get strangulated, it can become ischemic, necrotic, and patient may present straight away with sepsis, or the patient may straight away present with regurgitation, aspiration, and hemodynamic compromise. So how do we pick this up? This is on X-ray, ultrasound, CT, laparoscopy, or VATS. VATS can be used to even repair the diaphragmatic rupture. Now, my last injury, which is the rib fracture. Okay, this is the most common injury. Rib fractures can be multiple. It can cause flail chest, where there are multiple rib fractures with more than two fractures per rib. causing complete paradoxical breathing. The rib fractures can cause tear of the pleura and the lung and damage the intercostal vessels, so the patient can come with pneumothorax, hemothorax. And rib fractures actually is a big burden to the elderly patient, because they are the ones where the pulmonary mechanics go haywire. There is total lung capacity is reduced, there is compliance is reduced, there's ventilation perfusion mismatched, patient is hypoxemic. Most of the time the rib fractures, they come with pulmonary contusions. Pulmonary contusions cannot be picked up on day 1. It is always picked up on day 2 or day 3. There is blossoming of the contusions, which causes exacerbation of ARDS, and patient can land up in ventilatory failure. Rib fractures causes a lot of pain. So again, we have to tackle that. Pain again causes a lot of retention of sputum and atelectasis and pneumonia. So when we have rib fractures with flail chest or sternal fracture or rib 1 and 2, 3 fractures, then we should remember that it may be associated with internal organ damage also, like the heart and the great vessels. Now, as an anesthetist, rib fractures can be diagnosed, of course, on X-ray, but many times it is missed. So CT is the choice. We have to go ahead with a multimodal management of pain relief, because that is something that is going to decrease the morbidity and mortality in these patients. We in our ICU, we start immediately with IV paracetamol, buprenorphine, and all the patients do get in an epidural. But epidural, and we cannot put in an epidural if the patient is elderly on anticoagulants, if the patient is hypotensive, not maintaining mean arterial pressure. So what do we do for them? The new kid on the block is the erector spinae block, which can be given bilaterally. It can be given in patients who are old and on anticoagulants. One block can cover 3-4 ribs. So it's a more safer way of giving, and also an ultrasound can be used. So again, it is safe. The serratus anterior block can also be given, but what happens in this is it only gives analgesia to the anterior and not to the lateral chest wall. Many of the patients with rib fractures not only require oxygen through NRBM, but as the contusions worsen, they may require HFNC, NIV, and sometimes mechanical ventilation. Now, can these patients be for surgery? Yes. If there is a flail chest patient and he's on mechanical ventilation, then yes, he is a candidate to have his rib fractures repaired surgically. And in this also, we need to give one lung ventilation, so it can be provided either with the DLT or the bronchial blocker. Okay, so I'd like to again stress on my anesthesia concerns, or the goals of cardiothoracic anesthesia and chest trauma is that, one, we have to know our ATLS guidelines by heart. We have to know our airway, breathing, circulation, disability, exposure. There has to be continuous assessment and reassessment to catch the life-threatening injury at the correct point and save the patient and prevent the mortality. Emergency thoracotomy, yes, is a point to save the patient. Hemodynamic instability is always there with cardiothoracic trauma. So we remember our 6 life threats and our 6 potential life threats, which I've said. Permissive arterial hypertension in a hemorrhaging patient, keeping systolic blood pressure between 80 to 100 is allowed. Of course, the patient should not be having a head injury and many other injuries. Hypothermia, vasopressor infusion should be started early to reach target blood pressure. Hypothermia, coagulopathy, acidosis is always a part of the chest trauma, and we must try to avoid it by maintaining blood pressure, temperature, and tissue perfusion. Definitive surgical arrest of hemorrhage from major vessels is a priority. The patient needs to be wheeled into the theater immediately, even if he is hemodynamically unstable. Most of the chest trauma surgical interventions, they require left thoracotomy with 1 lung ventilation. There is a role of VATS in retained hemothorax, persistent hemothorax, diaphragmatic injury, post-traumatic empyema. Anesthesia plan is formulated according to the patient and the injury of the patient and the surgical consideration. Yes, we should be ready with our airway skills with direct laryngoscope, VL scope, or fiber optic, keeping in mind rapid sequence as well as manual inline immobilization. The drug of choice of anesthesia, etomidase, is the king of all. Small dose of ketamine can be given, and midastringent have always been the stable drugs to give in cardiac injuries. Nitrous oxide should be avoided. Low concentration inhalation agents can be used, and pain relief improves outcomes. These are my references. I'm very grateful to all my assistant professors who work 24/7 in trauma care and OT. My madam, Jyoti madam, for her beautiful chapter on chest trauma in our book, A Practical Approach to Emergency Anesthesia, and my present trauma ICU consultant, Dr. Devendra. Thank you.
Thank you, Urvi, for telling us about how the chest trauma should be managed. Now, I want all the speakers to come on the dais, and I request Dr. Sunil to conduct the question answer session. I'm sure that there are few questions from the audience side, and even I have few questions to ask. So all the panelists.
Thank you, madam. All three speakers gave an excellent talk, and I have a few questions. From the audience side, we have not had much questions. So I'll open the question session. Let's start with Dr. Nitin Sethi.
Yes, sir.
Dr. Nitin, you said that...
Can you open your screen? I can't see you. Dr. Nitin, Dr. Shikha.
I can see.
I think, Urvi, you have to unshare your screen.
Okay, 1 minute. First webinar, so I'm having.
Yeah, now we can.
Isha, how do I unshare the screen?
You have to unshare your screen. Now I can see Shikha, Nitin.
Yeah, all are visible.
Okay, fine.
Dr. Nitin, a few points that you presented. You mentioned in your table about lung recruitment.
Yes.
How do you recruit the lung in a one lung ventilation?
Yes, sir.
Yeah.
So ideally, earlier it was taught that you do a manual recruitment using a bag. But now what is that you have to do a lung recruitment using the ventilator. So what I usually do is that is the protocol given by Tunstall in one of his articles. I modified it a bit. Prior to starting OLV, on 2LV, I first start the recruitment. What mine is, I put the patient on pressure controlled ventilation, set the target pressure at 20, your respiratory rate at 10, IE ratio 1:1. And with a PEEP of 5. So target pressure 20, PEEP of 5. And then you increase in increments of 5 increase the PEEP, because the driving pressure should remain 20 at all the time. Target pressure 20, PEEP of 5, you ventilate with the IE ratio 1:1, you ventilate for 30 seconds. Then increase the PEEP to 10. Your target pressure remains is still 20. So your total, your driving pressure becomes, your plateau pressure becomes 30. The PEEP is 10, your driving pressure becomes 20. Then you ventilate for another 30 seconds with 1:1 setting itself. Then after that, you increase the PEEP by 5 more. So your PEEP becomes 15. Your target pressure remains 20. So your driving pressure becomes 35 minus 15. Again, 20, you ventilate for another 30 seconds. This I'm talking for a normal lung, not for a patient lung with emphysema or the... Yeah. And in the end, you increase the PEEP to 20 again, then for 1 minute. So total cycle is 2.3 minutes. But at all times, you have to keep in mind the hemodynamics. At any time there is going to be hemodynamic compromise, you have to abort this artificial recruitment maneuver has to be aborted. And also in patient is suppose an emphysema patient or a COPD, in that you cannot give high PEEPs because lung injury chances are there. But more or less in many of the patients, I found this artificial recruitment maneuvers to be quite very effective, not only for thoracic, but also for laparoscopic in abdominal other surgeries also. And this is a protocol in various studies, Tunstall and all, they have given this. And another is you do a cyclic recruitment maneuver. In cyclic recruitment maneuver, you increase the PEEP in steps, looking at the patient compliance. The point at which the compliance begins to deteriorate at that PEEP level, then you set a PEEP level 2 less than at which you're getting a proper compliance, and that becomes your PEEP which you should give to the patient. So
yeah, you're talking about dynamic compliance, but you have to manually calculate. It will not be available on the anesthesia machines.
But some total lung compliance, some ventilators do give your compliance values. So I rely on the dragger and all.
Yeah, endpoints for adequate recruitment are not it's not exactly possible to know in the OT.
Yeah, but I usually go for if there's because normally what will happen, sir, is like once you do these maneuvers, your oxygenation won't start rising immediately. Once you keep on cyclically increasing the PEEP, obviously, once you come back to your original settings, you will see that your tidal volume deliver increases and the oxygenation starts rising after a few seconds. And it's very
the same tidal volume now gets delivered at a lower airway pressure if you have recruited.
Yeah, that at a lower airway pressure. And for me, it's pressure control ventilation is the key. That's what I do. And at lots of times, what happens is one more thing which I practically do is your airway pressures are rising. You are set an I ratio of say 1:2, but you can go on low on the I ratio. I tend to reduce the I ratio so that I don't compromise on my airway pressure. Then that also gives you a good tidal volume delivery if you are not able to achieve, especially when they're doing a capnothorax and insufflating carbon dioxide. And that maneuver also, it's like you're ventilating during a restrictive lung. So reducing the I ratio also helps a lot.
Your preferred mode of ventilation, I understand, is pressure controlled ventilation.
Pressure control.
Is it same for the other speakers?
Yes, even I prefer.
Dr. Nitin,
Can I ask something here?
Sure.
I just want to know how much maximum PEEP you can give it in such kind of the situations.
Ma'am, just for recruitment per se, you can go up till 20, but that only for few seconds, but also looking at the hemodynamics. After that, you come to your baseline setting of PEEP, so 5 or 7, or if you can have, as sir told, you can look at your compliance and what is the optimal PEEP at which you are getting good compliance. That is not practically very easy to do all the time. So what I usually do is set a baseline. Suppose I'm ventilating patient as a PEEP of 5 or 7. Firstly, I recruit using this maneuver, then come to a baseline, say 5-7 PEEP, and at which your good tidal volume is delivering.
So maximum up to 20 can be used.
Yeah, can be used, but looking into point of hemodynamics and the patient's lung.
Yeah.
If it's
by
a bulla and all, obviously bulla's lung disease and all, you cannot go on high pace.
No, that is okay. That means by keeping all the hemodynamics, we can give up to 20.
20.
And my second question is that how much should be the duration of training to the newcomers, those wants to learn the advanced thoracic surgery anesthesia?
Ma'am,
according to your experience and your practice.
Ma'am, frankly, I will tell you, when we started we were doing thoracic. I did in my training also, when I did my DNB, some amount of maybe thoracic was done. But I think since 2012, we had a team which was doing roughly around 100 to 120 thoracic cases a month. So I typically in a year end up doing around 50 thoracic cases a month. A year, sorry, 50 to 60 thoracic cases a year. But if you are, very well versed with principles of general thoracic anesthesia, it won't be a problem. Obviously,
so
I think
3 months or 6 months.
I'll say 3 months is a good time period if you are exposed reasonable, say 10 thoracic cases a month. So a week, sorry, at least 5 or maybe 20 a month is gives a whole lot of.
The centers like yours.
Yeah, because our center is offering, one of those centers offering WFSA fellowship in thoracic anesthesia.
Okay.
So we have offered a 6-month fellowship in that.
Okay. Yeah. Dr. Sunil, you want to know something else?
Yeah, Dr. Sethi, once again, with regard to lung collapse for VAT surgery, you mentioned how important it is, and you gave 3 which must be meticulously followed to achieve complete lung collapse. But the point at which you come to know whether the lung has completely collapsed or not is when the surgeon has inserted his scope.
Definitely.
And, has it happened to you that at that time the lung is not adequately collapsed or not collapsed enough for that surgeon?
Yes, sometimes it does.
What do you do then?
So it does happen. Obviously, at that time, ventilating with 100% oxygen is not an option. What mostly we follow is either putting in a catheter and applying some suction. That's what I routinely do. And first of all is to check the positioning. Quite often it also happens, I think 40, 30, 40, 50% of the time it is that your cuff has moved out a bit. Your positioning of the tube has got is wrong. So that may sometimes, so repositioning has to be done. Obviously repositioning in a lateral position is a challenge in itself, because you know your tube is all, you have fixed the tube, you have to remove the fixation. But so most of the time we get away with applying suction to the non-ventilated side. So.
Okay, just for the benefit of the listeners, the 3 steps which you should follow early is ventilate with 100% oxygen before you go in for lung collapse. The purpose is to achieve denitrogenation. Then apply a suction to the operative site, and as Dr. Nitin has mentioned, avoid and prevent room air from entering that lumen. Those are the 3. Yeah.
And for the postgraduates, a point of caution when the suction is, please remove the suction prior to firing of the staplers. It has happened. It has happened with me also. So it has to be a drill. Even the surgeons prefer to have a drill. All catheters out at the time of firing your staplers, because that you have to make sure at firing the stapler, the suction should not be inside. It will get fired in the stapler and it will be a problem. That has to be kept in mind.
You also mentioned a bronchoscopic guided oxygen insufflation into the zone of into an area where the surgeon is not working. Yeah. How well does that work? Have you tried?
So I don't use it that routinely. Use it very few time, because that also disturbs the surgeon. Because you're giving the oxygen, the lung will start inflating at that time, and the surgeon does not like it. Most of the time, the surgeons, what they prefer is they get away. Our surgeons prefer putting a capnothorax all the time to increase the exposure. But sometimes you have to be careful. The surgeons in their, you know, they obviously they don't go beyond 10, but sometimes they may increase. And capnothorax then has hemodynamic problems you do face with the capnothorax. So that procedure of oxygenation using is very not routinely used, but sometimes you may have to use. And many of the times by increasing the FiO2 and all, you can get away. But then you have to understand like how much SpO2 is acceptable. For me, even if it is going till 90 for some time, I accept. But if it is going less than 90, then you have to tell the surgeon quite often that we take the patient on 2 lung, ventilate for some time. Obviously, those are the last measures which you may have to resolve if nothing improves.
Dr. Nitin, again, you brought up the point that you must put intravenous big bore access and venous lines on both upper limbs.
Definitely.
Why not go in for a lower limb venous line? The question also goes to Dr. Urvi Desai. She deals with chest trauma, where venous structures in the chest or neck, they can be avulsed, injured. So,
so most common what I have, encountered is this injury to the site at where they are operating. Very rarely it has happened that both sides they may injure. Although I agree it has happened to be once only, where they somehow they ended up injuring brachiocephalic veins on either side. But mostly, if you put large bore on either of the both the limbs, it suffices most of the time, majority of the time, because it's very unlikely they'll injure both the sides. But obviously, that's a good point. Having a one axis and the lower limb also is not a bad idea. But mostly, you can get away by having in both the limbs. Upper limbs.
Dr. Urvi Desai, I saw a picture that you presented. There was an internal jugular venous line. Wouldn't you prefer a lower limb line in such a situation, let us say in the femoral vein? You're not audible.
Urvi, can you share your screen now? Urvi.
Yeah. Okay. Now can you hear me?
Yes.
Yeah. So what happens is when the patient is wheeled in, we take the best available IV line at that moment, which is there. And something which is large and big is the EJV. I think what you saw in that picture was the extrajugular vein, which was taken. and the patient resuscitated. And when the patient was wheeled in the OT, yes, we must have gone for, we did take an IJV, because that time we realized that the patient had a penetrating injury to the heart. It was seen on the X-ray that the screwdriver is going inside the heart. What you're suggesting to take lower limb femoral veins, yes, we can go ahead, especially if the great vessels are involved. If I know that for some reason there is a great vessel injury, but that I would never know unless I do a thoracotomy and then find out.
Can I say something here?
Sure, madam.
That lower limb veins are really not advisable in view of so many other problems. And whenever such kind of the patients are coming to us, we always try to take the internal jugular or subclavian or external jugular even. And I want to know one thing from Urvi, that what advanced monitoring you would like to advise in such kind of the patients? Advanced monitoring.
Yeah, if we have a TEE in cases of penetrating cardiac injuries, and we're doing that would be a very good thing, transesophageal echocardiography. Otherwise, our normal invasive arterial line monitoring and our will have many of the good, directed monitoring, like we could get a pulse pressure variations, and we could get everything just from an invasive arch line and go ahead.
What about the cerebral oximetry and internal jugular?
Yeah, we should have anesthetic depth monitoring. We must have wherever it's available and possible.
No,
And
I'm not talking about the depth monitoring. I'm talking about the oximetry, cerebral oximetry.
Yes, we should have it. If it's available, we should have it.
So you advise that cerebral oxygen saturation should be monitored in such kind of the trauma patients.
Yeah, penetrating cardiac and great vessel injuries, yes, I advise.
Okay, and I want to know one thing from Dr. Shikha, that how much oxygen fall is advisable from the baseline in advanced endobronchial surgical patients? How much fall in oxygen saturation from the baseline is permissible for advanced endobronchial surgical patients?
Yeah, usually what we are doing is we are taking FiO2 of 1, most of the procedures, unless it is a laser or an argon or some cautery in which there is a chance of fire. But as a thumb rule, yes, a 4% decline from the baseline could be acceptable.
4%?
Yes.
Not 10%?
I usually take it as 4 to 5%.
Okay.
Yeah.
Okay. Thank you very much. Any other question?
A question from audience. In mediastinal tumors involving SVC, should we consider femoral vein sheaths in advance to deliver volume if SVC is injured intraoperatively? That is from the audience.
Yes, look, what happens is surgeons, whenever if it's a large tumor involving the great vessels, SVC and all, they prefer to do it in a cardiac setup with a bypass available standby. And many times, if it is really encasing the SVC and involving the larger vessels nearby, then they prefer to go on a bypass and then do such cases. And it is obviously advisable to have your ECMO devices standby, even if you're not planning to buy when you're doing such cases. And obviously look at which structures, then obviously the lower limb access may be needed in such cases. If bilaterally you are involving the great vessels, obviously if SVC involved, then giving fluids from the upper limb will be a difficult task. Then you have to go in for more access.
Dr. Ashika Sharma, I do not have much experience with many of the procedures you presented, but I've done a few cases of tracheal stenosis and tracheal stenting. But in those cases, we have always used local anesthesia for the airway along with TIVA. So what's your experience with regard to airway blocks along with general anesthesia?
We usually use total intravenous anesthesia using an iGel and a flexible bronchoscope for stenting in our procedure. We have not used airway blocks. Yes, local we have given in a few cases where the airway is really compromised, but never have done under airway blocks.
Must be with the difference of interventional physicians we are dealing with, our interventional physicians are comfortable going through the nose. So any airway we put, they will want us to remove at the time of stenting. So for us,
prefer the eye gel. They find it very comfortable with the eye gel.
Our physicians want to go only through the nose. So for us, any artificial airway cannot remain there at the time of dilatation or at the time of stenting. So that's I mean, I don't know. This is our experience. Okay. How do you manage fluids? I mean, this is open to all the speakers. What are the guidelines that you follow? How do you prevent post-operative pulmonary edema? Because that never came up.
I think the only point where we have to restrict our fluids in chest trauma is with patients who have lung contusions. I mean, those are the patients where I would be telling my residents, let's go slow on the fluids. Let's go.
Obviously, like the guidelines do say lung resection surgeries and pneumonectomies, judicious, don't use too much of fluids, try to maintain an output of 0.5 ml per kg per hour. That's what our surgeons always, when you're doing a pneumonectomy, keep the patient dry, keep the patient dry. But I personally feel there's a flip side to it also. Too much of dehydrating the patient also sometimes becomes detrimental. If I have an arterial line in place, I do look at the trends of the lactate, because you may not be doing your this minimal invasive cardiac output monitoring all the time. Look at your arterial tracing also. Is it showing too much of hypovolemia while restricting too much of it? Is your lactate rising a bit? Because what happens if you are restricting too much of fluids, the patient ends up in tachycardia, his lactate starts building up, and that also starts a vicious cycle again. So what personally I believe is you have to balance it, how your patient is going intraoperatively. If by restricting fluids, you're maintaining urine output, there's not too much of tachycardia or lactate is within range, okay, you could go out of restriction. But if anytime your lactate is going out of hand, your tachycardia is increasing, your arterial trace is too much of hypovolemic, then you have to give in some fluids. You cannot just completely, just go by the surgeon, keep him dry. So that's how I go about it. You have to, case by case basis, you have to determine how the patient is behaving intraoperatively.
That trauma guidelines tell you that you need to give fluid to the patients when they come before we start actually finding out what is the reason for his, the injury. So initial fluid resuscitation is a must, and arterial waveform in the ED is not possible. In the OT, yes, it's possible, and that's a very good way of monitoring our pulse pressure variation, and that's how we are managing our fluids in the OT, just by looking at the arterial waveforms.
Yeah,
and the urine output.
Obviously, both of you are talking about different substrates. Thoracic trauma needs to be handled differently than a patient who is undergoing lung resection for, let us say,
lung resection and lung injuries. The fluids need to go down. That's true. That's common.
Another question from the audience: what is the cutoff values of pH and blood gas values for thoracic surgery, especially endobronchial?
In endobronchial suite, we usually do not put in an A line, so that we cannot really comment on the pH values. For the lung resection surgeries, yes, we put in a line, and I think Nitin will then answer that.
If you are talking about the preoperative evaluation of the patient, I think it was a pH. For pH, like obviously, I don't think I've encountered patient coming for lung resection with a very high CO2, unless patient is coming for bullectomies and he requires a bullectomy or a lung volume reduction surgery, or he's in respiratory failure, then maybe the CO2 will be on the higher side. But there's no definitive cutoff value that we won't take up this until the pH is too low. Then that patient will be on some sort of a ventilatory support. So obviously that becomes a contraindication. But if the patient is, he's taking care of himself preoperatively, he's, if he's well enough to walk into the OR and he's been maintaining that way for the past few months, able to maintain himself, not on any requiring ventilator or BiPAP support, then you can take up the patient. I don't think I've ever
I think we should conclude now and stop the questions.
Yeah, I think we have exceeded time. I agree. Sanish?
Is it okay?
Jayashree ma'am?
Yes, yes, absolutely. I think we've had a very nice discussion. Of course, the lectures were excellent, and the students can, of course, always ask us questions later as well. Manjula, have we covered everything in the chat box? Because there were some questions. I hope we've covered all of them.
Yeah, we have covered all, madam.
Yeah.
I have checked.
Okay.
I have checked the chat box.
Stuff. Right. Okay. So I think we'll ask Dr. Baljeet to conclude. And of course, we've all enjoyed it very much. And they were very, very educative and practical points that all three of them, Urvi, Shikha, Nitin, have been highly appreciated. Thanks a lot. Baljeet?
Madam, can I say something here?
Of course.
Yeah, I thank Anesthesia TV and Mr. Rahul Chaube also, who has really done the wonderful job for us today. And he has agreed to do it for the future also for our webinars. So I thank Rahul Chaube. Thank you very much.
Yes.
And madam, now you can ask Dr. Baljeet to conclude.
Yes, yes, yes. We would all like to thank them, the Anesthesia TV. Yes.
Good evening.
Baljeet, are you there?
I'm there. Very good evening.
Yes.
And all good things must come to an end. First of all, I compliment all the speakers. There was a lot of new information which Dr. Nitin Sethi had given, and of course, Dr. Shikha as well. And some amazing management of very challenging cases by Dr. Urvi and her team in that hospital. I think there's a lot of learning, particularly for the youngsters here with this webinar. And of course, it was very well moderated by Dr. Sunil. And, there was what pleased me the most was the way the speakers had handled the question answer session and how they justified what they're doing and, how all whatever challenges they come across during surgery or they come across before that. Great discussion, and thank all the participants also who asked questions, and of course the speakers who handled these discussions. Well, till we meet again next week for another exciting webinar on Wednesday on the valvular heart disease. Friends, on behalf of Indian College of Anesthesiologists, the President, the CEOs, and the Dean, and everybody here, from Indian College of Anesthesiologists, I thank everyone. The participants, yes, of course, the speakers for their wonderful talks, and Dr. Sunil also for, coordinating and moderating the discussion. Thank you so much. Very good night. Thank you, sir. And we meet again next week.
Thank you. Thank you, Dr. Baljeet. And thank you, everybody.
Thank you. Good night. Good night.
Good night.